Greetings. This is a replica of my talk given at the Heart Failure Association of India conference held at Kochi in February. The topic of the talk is reversible non-ischemic causes of heart failure. The objectives of my talk are to talk about the contribution of these various factors to causing heart failure and how management of each of them can result in reversal of the heart failure to a certain extent. So, electrical overactivity, dysynchronous normal electrical activity, inflammation, cardiac overactivity due to increase in the sympathetic tone or in the increase in sympathomimetic amines, direct chemical myocarditis are all probably reversible causes of heart failure which are non-ischemic. Let's start off with a case for a common presentation that we see. A 54-year-old male, overweight, hypertensive, diabetic, having atrial fibrillation on the ECG, presenting with dyspnea on exertion, effort intolerance, palpitations and fatigue for the last 6 months. The coronary angiogram done showed a significant lesion in the left anterior descending artery. The obtuse marginal had 70 to 80% lesion and the right coronary artery had 80% tandem lesions. This was the chest X-ray of the patient showing a vertical heart and increased vascularity in the lung fields. He was referred for a bypass. His ejection fraction was 30% at the time of presentation. Not a very great echo, but if you can see, the heart is not moving very well. The thickness seems to be maintained, but there seems to be global hypokinesia. Obviously, the fast rates and irregular rates are well noted. He was admitted, IV diuresis done, the atrial fibrillation was controlled by rate control, anticoagulation was given, heart failure medications were started, patient was improved symptomatically. When referred for a bypass surgery, the surgeons were apprehensive about taking him up. Therefore, he was then referred to the electrophysiology department for further management. After optimizing his medications, we took him for an ablation, and post-ablation, successful restoration of sinus rhythm was present. 1 month post-procedure, as you can see, the thickness of the myocardium is still maintained, but overall the contractility of the muscle has improved, giving you an ejection fraction of close to 45%. This patient subsequently underwent a bypass surgery because he did have angina now that he was able to exercise more and therefore required the intervention. So from an ejection fraction of 25% to an ejection fraction of 45%, this was the reversal in the heart failure by the arrhythmia itself, and maintenance of sinus rhythm gave you a reversal of heart failure, and the heart failure was due to a non-ischemic cause. Here, the arrhythmia resulted in an exacerbation of pre-existing heart failure, which was probably ischemic. Looking up ahead, let's take a case where you see an ECG showing a narrow complex tachycardia. Again, presented with an ejection fraction of 25%, age of around 14 years, young person. Clearly, the P waves seen on this ECG are unlikely to be sinus. There seems to be 1:1 QRS to P association, suggesting that perhaps we are dealing with some kind of SVT or atrial tachycardia. The patient was taken up for an ablation after stabilization. the focus mapped and ablated in the superior crista, and sinus rhythm restored. Post-restoration of sinus rhythm, we got a strain and compared it to the pre-procedure strain. As you can see, from an ejection fraction of 32%, the ejection fraction improved to 56%, and the global longitudinal strain improved from minus 9.6 to minus 17.3. So there is reversal of even strain abnormalities, and in this case it was truly the arrhythmia itself that was contributory to the heart failure, thereby another cause of reversible non-ischemic heart failure. Another lady, a 12-year-old female here, presenting with heart failure, low ejection fraction, and ECG suggestive of left atrial enlargement, right atrial enlargement, and frequently punctuated by these PVCs. PVC morphology was very similar to a morphology close to the arising from an origin close to the fascicular system and was closely coupled to the previous sinus beat. This PVC was ablated from the posteromedial papillary muscle in the left ventricle, and upon restoration of sinus rhythm, the ejection fraction of the patient similarly improved from an LVEF of 20% pre-procedure to a post-procedure LVEF of 64%, with a significant reduction in the burden of PVCs from 50% to 2%, and these 2% were not the morphology that we ablated, with similar significant improvement in the global longitudinal strain. Thereby again a ventricular focus of an arrhythmia contributing directly to the cardiomyopathy in this patient, which was reversible. There was no ischemic component here. Finally, a 13-year-old female with a 20% ejection fraction showing a narrow complex tachycardia with a 1:1 P to QRS association, and the P wave is positive in V1 and negative in inferior leads. Again, with a young female having a persistent tachycardia, one common differential remains a PJRT, wherein the arrhythmia will be sensitive to adenosine, and upon mapping, we did ablate an accessory pathway in the posturoseptal region. Post-ablation, the patient's ejection fraction improved, again showing an anatomical accessory pathway mediated tachycardia, resulting in cardiomyopathy, which again was reversible and non-ischemic in nature. This was the echo which was currently present for this patient, showing good contractility and good pumping function with improvement in the valvular lesions. So, essentially, an arrhythmia inducing a cardiomyopathy can be classified as either the arrhythmia worsening a pre-existing cardiomyopathy, as was seen in our first case, or an arrhythmia itself being the cause of the cardiomyopathy. In both cases, we may have to ablate the arrhythmia in order to improve the pumping function or the ejection fraction and thereby stabilize the heart failure. The degree of recovery back to normal depends on which of the two mechanisms was responsible for the worsening and the presentation of the patient, and it is not uncommon to see atrial arrhythmias, especially atrial fibrillation in the elderly group, where the arrhythmia exacerbates a previously stable patient or previously compensated patient with heart failure. Again, restoration of sinus rhythm is perhaps the most important step in these patients. Wherever possible, ablation can be used to restore sinus rhythm. If ablation is not possible or not available, medications to restore sinus rhythm are welcome. There is recent evidence to suggest that some of the patients with arrhythmia-induced cardiomyopathy may have underlying genetic mutations, especially, for example, mutations, single nucleotide mutations in the HCN4 gene, which are responsible for early onset AF, mutations in the ACE gene, which are responsible for ventricular dysfunction, and which may be first diagnosed with the help of PVCs, Titin, KCNA, MYH7 mutations, which are responsible for atrial fibrillation in patients less than 30 years, and recently, the Titin mutations responsible for PVCs coming from Titin mutations, which are seeming to be associated in patients having PVCs originating from the LV summit. In these cases, the degree of reversal back to sinus may be variable, but definitely there seems to be benefit in improving the existing ejection fraction by management of the arrhythmia itself. So, as I mentioned, arrhythmia-induced cardiomyopathy is either arrhythmia-mediated cardiomyopathy or arrhythmia contributory to the cardiomyopathy itself. In the Framingham Heart Study, with participants between 1948 and 1995, the incidence of heart failure among patients with atrial fibrillation was 33 per 1,000 person years, whereas incidence of AF among those with heart failure was 54 per 1,000 person years. AF subsequently led to heart failure and led to increased mortality with a hazard ratio of 3.1 in women, and hazard ratio of 2.7 in men. And when patients with congestive heart failure developed atrial fibrillation, mortality again increased to the tune of a hazard ratio risk of 1.6 in men and 2.7 in women. What is important to note is that women did worse when atrial fibrillation supervened. So we have had this debate about atrial fibrillation, rate rhythm control, and so on. And the AFFIRM trial was a very important trial with respect to that. But when we have advanced or additional data recently produced from the EAST-AFNet trial, which is, in my opinion, the AFFIRM trial of our generation, where they used early rhythm control therapy in patients with atrial fibrillation. They used a parallel group open-blinded outcome trial consisting of close to 2,700 patients of atrial fibrillation, randomized to either usual care, that is rate control therapy, or early rhythm control therapy consisting of antiarrhythmic drug or AF ablation. It was found that in patients where early rhythm control was instituted, there was a significant decline in cardiovascular death, stroke, and hospitalization with worsening heart failure or acute coronary syndrome. And the number of nights of hospital per year, however, remained constant. Serious adverse events resulted from rhythm control therapy happened in 4.9% of patients compared to 1.4% of patients assigned to usual care. Therefore, an early rhythm control was associated with lower risk of cardiovascular outcomes than usual care among patients with early AF and cardiovascular conditions, at perhaps a slightly increased risk of serious adverse events in the rhythm control therapy arm. Here, rhythm control strategy was mainly antiarrhythmic drugs or ablation and or cardioversion of persistent atrial fibrillation. Both the groups were in the first year of AFib diagnosis with at least two conditions which were contributory to cardiovascular morbidity. So, in patients who had previous cardiovascular comorbid conditions, sinus rhythm maintenance had value. The other extreme is the Castle HTX trial, where patients of atrial fibrillation with symptomatic AF with end-stage heart failure eligible for heart transplantation, when randomized to first-time catheter ablation of AF or medical therapy for AF, had their study stopped for efficacy by the Data Safety Monitoring Board 1 year after randomization was completed. Here, the composite of all-cause mortality, worsening heart failure requiring urgent heart transplantation or implantation of LVAD was significantly less, with a great confidence interval of 0.11 to 0.52 in these patients, suggesting that at every extreme of heart failure, patients where arrhythmia was managed to sinus rhythm, you had a reversal of the heart failure, and as such, arrhythmia induced cardiomyopathy or arrhythmia precipitating worsening of pre existing cardiomyopathy could be managed with maintenance of sinus rhythm. Finally, the APAF CRT contribution to this story is where patients with permanent atrial fibrillation and narrow QRS being randomized to AV node ablation and CRT did show that AV node ablation plus CRT had reduction in heart failure related morbidity and mortality when compared to just medical therapy, suggesting that extreme rate control by ablating the AV node, removing the RR interval variability was perhaps the way to go, especially if the patients did not have access to ablative forms of therapy or giving medicines to maintain sinus rhythm. So going on from arrhythmia induced and arrhythmia precipitating or worsening pre-existing cardiomyopathy, let's go to dysynchronous arrhythmic activity in sinus rhythm. And one of the commonest reasons for dysynchronous activity is the presence of the WPW or the accessory pathway, wherein you can see in this figure that this is the ECG when the accessory pathway was present. There is the left bundle branch block morphology with a short PR interval of 100 milliseconds, which when ablated to a sinus rhythm, giving you a narrow QRS and a normal PR, did improve pre-existing cardiomyopathy and reversal of the dyssynchrony caused by the left bundle branch block resulting from conduction to the ventricle over the accessory pathway reversed when the pathway was ablated. Here, the elimination of the pathway was beneficial in improving the ejection fraction even without any atrial fibrillation or atrioventricular reentrant arrhythmia mediated by the right-sided accessory pathway. Here, important to note that it is the septal posterior wall delay on echo, and higher the septal posterior wall delay, higher the chances of a cardiomyopathy happening due to the dyssynchrony, rather than figuring out what the width of the QRS is and correlating possibility of cardiomyopathy based on the width of the QRS. Another example of this concept is the oft seen and oft repeated possibility, oft seen and oft discussed possibility of pacing-induced cardiomyopathy or a left bundle branch block by itself, where putting a CRT or a cardiac resynchronization therapy device in results in alteration in the vectoral depolarization of the left ventricle, thereby improving the ejection fraction of the patient. This is another example of dysynchronous electrical activity resulting in heart failure, which is reversible and non-ischemic in nature. Here, the degree of reversal may not be certain, but changing the activation resulting in better synchrony will improve the ejection fraction from the pre-existing low and may or may not entirely correct it depending on the underlying comorbidities. Finally, an intervention induced creation of left bundle branch block, namely the right ventricular pacing, and thereby resulting in LV dyssynchrony, which in turn leads to a condition called left ventricular pacing induced cardiomyopathy, wherein it is the pacing from the right ventricle that results in lowering of the ejection fraction. Over a series of studies, its incidence is close to 5% per year and is largely mitigated by placing the lead properly in the septum at varying depths using either left bundle area pacing or deep septal pacing, resulting in better resynchronization in these patients and variable reversal of the cardiomyopathy. Going on from conduction and arrhythmia related cardiomyopathy to another cause of non-ischemic, possibly reversible cardiomyopathy is the postpartum cardiomyopathy, where the cause is unknown, patient presents with heart failure, secondary to left ventricular systolic dysfunction, towards the end of pregnancy or in the months following delivery, which remains a diagnosis of exclusion. EF is almost always reduced below 45%, with an unusual presentation of the ventricle being dilated, where based upon the severity of the PPCM, management is instituted and both bromocriptine and cabergoline can be used to improve the pumping function or the ejection fraction of these patients. Supportive measures with oral heart failure medications are useful, and it is still a challenging area to work with regarding prevention of sudden cardiac arrest. Outcomes have always been worse in patients with lower ejection fraction, delayed diagnosis, dilated left ventricles, and those with the African American race. And the long-term outcomes mainly depend upon the optimal duration of medications being given, longer the better perhaps, and in case of stopping medications, they need to be stopped gradually and close observation needs to be present for these patients. Going from postpartum cardiomyopathy to a chemical form of cardiomyopathy, where cancer therapy related cardiac dysfunction can result in various forms of therapy related cardiac abnormalities, namely ejection fraction, wherein the patients can either be symptomatic or asymptomatic and have varying forms of functional classes. Management depends on the severity, especially in patients with immune checkpoint inhibitor mediated myocarditis, where it needs to be discontinued. Methylprednisone needs to be given once a day for 3 days, that is the pulse steroid therapy, and then the patients either recover or remain hemodynamically unstable, progressing on to fulminant myocarditis. If it is amenable or responsive to steroids, complete recovery can be present for these patients. But in other patients having myocarditis due to drugs like bevacizumab or any of the anthracyclines, complete recovery may or may not be present. Use of the global longitudinal strain to diagnose these cases early and having serial measurements to be able to pick up patients having abnormalities can be a useful technique. However, standardization of the values for the GLS is not very common across providers, and as such, it requires serial measurements and a 15% decline to diagnose these conditions. Moving from chemical myocarditis to inflammatory myocarditis, namely commonly to inflammatory myocarditis, where sarcoid involvement of the heart, tubercular involvement of the heart, viral infection mediated cardiac myocarditis can all present of cardiac muscle can all present with varying forms of non-ischemic cardiomyopathy having reversibility with or without intervention. In cardiac sarcoid, 20 to 27% of patients have extracardiac disease, but when there is isolated cardiac sarcoid, there is more severe LV dysfunction and as such can present in varying phenotypes on the CMR and the FDG PET, corresponding to abnormal ECG findings, classic of which is the presence of a bradycardia related condition, namely a bundle branch block, a prolongation of AV delay, a prolongation of AV interval, or a complete heart block, and simultaneous presence of a tachycardia like syndrome where you may have PVCs, atrial fibrillation occasionally, or atrial arrhythmias, non-sustained runs of ventricular tachycardia coming from close to the conduction system, which should trigger the possibility of having inflammation mediated cardiac involvement. Various guidelines are present differentiating isolated cardiac sarcoid from proven cardiac sarcoid from tuberculosis and other viral related infections. Till now, the FDG PET was used as definitive diagnosis for inflammation within the heart. However, recent data seems to suggest that it may be even murkier, wherein genetic cardiomyopathy might also show abnormality on the FDG PET, consequent to the stress the myocardium is under and therefore the glucose uptake being present. So in any patient presenting with normal sinus rhythm and or conduction mediated disease with or without arrhythmia in a burden that may not be sufficient enough to contribute to the cardiomyopathy independently, and there is no ischemic reason for the same, we might have to end up doing the MRI, the PET scan, the strain analysis of the atrium and the ventricle, and a genetic analysis to be able to accurately classify these patients under what category of disease they come. Treatment targeted appropriately to those diseases might improve the reversibility, especially when there is a high index of suspicion. From these cases to a more endocrine mediated cause of heart failure, namely the high output cardiac failure, where because of overworking of the heart itself, there is a higher output that the heart has every minute, thereby leading to cardiomyopathy. The usual causes of this are heightened sympathomimetic amines in the body, namely with thyrotoxicosis and beriberi, and these are very reversible by treating the underlying condition, but during the acute flares or the acute presentation, vasodilators and other usual heart failure therapy may be detrimental. The key to the management and the ultimate reversal of the heart failure in these patients is the diagnosis of the underlying reason due to which the heart failure is there, especially the cause of the overworked heart, and treating that will result in improvement of the heart failure. Stress cardiomyopathy, aka Takotsubo cardiomyopathy, is a temporary acute left ventricular dysfunction, probably because of a surge of sympathomimetic amines, resulting in regional wall motion abnormality extending beyond a single coronary artery, which is not benign, having substantial morbidity and mortality, and can easily be confused with an acute myocardial infarction owing to the chest pain and the ECG features. But typical for these patients is the presence of the apical abnormalities where the apex of the heart is not contracting, whereas the base of the heart contracts well enough. And the apical ballooning that you can see in these patients is very, very characteristic. This usually occurs owing to presence of pre-existing emotional stress, physical stress, in concert with risk factors like the female sex, postmenopausal, asthma or COPD, diabetes, chronic medications or substance disorder, and is mediated by catecholamines and the neuropeptide Y, resulting in acute microvascular dysfunction, direct cardioinhibitory effects in the setting of impaired coronary reserve because of the risk factors, thereby leading to stress cardiomyopathy. It can either be the typical apical ballooning variant, the midventricular, the basal or the inverted, or finally just focal dysfunction, which can contribute to abnormal cardiac function. When managed through the acute stage, this can be reversible and disappear without leaving any traces. One interesting pearl is the presence of these episodes, especially post an electrophysiology study wherein high doses of isoprenaline might have been used during the course of the study for either testing or inducing of the arrhythmia, and the next day the patient might go into heart failure because of Takotsubo or stress-induced cardiomyopathy. Management remains the same, where diuretics and nitroglycerin can be used for fluid overload. If the patient is not in acute heart failure, beta blockers may be given, thromboembolism prophylaxis might be required, and all the 4 foundational drugs might be given for management of these patients. In patients with arrhythmias in this myocardium, it may be beneficial to avoid drugs that prolong the QT interval. Finally, when dealing with a patient having non-ischemic cardiomyopathy, the reversibility also depends upon understanding the ECG. To stress home this point, let me present to you this case of a person who presented to us in florid failure. This ECG suggestive of bursts of some narrow complex rhythm. And if you look at the ECG, at first sight, it seems as if this looks like some form of a sinus tachycardia. But upon closer inspection, you can actually note that the P wave is inverted in lead V2, in lead AVL, whereas it's positive in lead 1. So using only lead 1 and lead AVF to determine whether the P wave is sinus or not is fraught with challenges. One must also look at lead V2. When this patient was taken up in the lab, a perisinusoidal focus of the arrhythmia was noted, and the clue to that was this negative P wave in lead V2, which is almost never positive unless it is a sinus exit. All forms of sinus exit will have the P wave positive in lead V2, whereas if the lead P wave in lead V2 is negative, it's always a non-sinus exit of the P wave or of atrial depolarization. This is the sinus ECG of the same patient, where we can actually see that upon restoration of sinus rhythm, the P wave in lead V2 has gone back to normal. In summary, therefore, reversible non-ischemic causes of cardiomyopathy are varied. There are electrical causes which can either be responsible for it or contribute to worsening. Maintaining sinus rhythm in patients with atrial fibrillation and heart failure has mortality benefit. It can either be via ablation or via medications and has benefits on both ends of the heart failure spectrum, both in early disease and in late disease states. Ventricular arrhythmias contributing to heart failure may have underlying genetic mutations, as does early onset atrial fibrillation. So the reversibility after reversing the arrhythmia may be variable, especially if there is an underlying genetic mutation. Inflammatory cardiomyopathy needs early detection, but needs to be tempered for the diagnosis of isolated inflammatory cardiomyopathy states, especially because of the finding that even genetic cardiomyopathies may have positive PET scans. A cardiomyopathy exome panel might be very useful in these conditions. Chemical myocarditis induced by chemotherapeutic drugs is common and is getting to be seen more and more these days. Early diagnosis using strain, either as an absolute measure or in serial measurements, may have value. Finally, an overworked heart, either because of increased catecholamines or because of a high surge in the same during a very short period, can contribute to cardiomyopathy. Rest and treatment of the underlying cause is valuable in these cases. Sometimes just being able to read an ECG properly might actually solve the problem. None of this work would be possible without my collaborators. I thank them for helping me prepare this. Thank you for your patient listening.